Hello everyone. Our talk today about patient radiation protection in interventional radiology. My name is Islam Kamal Mamoon. I'm a PhD holder in medical physics, international board certified in medical physics. I'm working as a medical health physicist at Pittsburgh University, United States of America. Our outlines today for part 1, the objectives of patient radiation protection. How can we reduce the radiation dose using different factors like distance, patient size, grids, image receptor position, projection angle, and collimation. The objectives of patient radiation protection are to protect the patient from deterministic effects like skin burn, tissue damage, sterility, and to optimize X-ray exposure to minimize risk of stochastic effects like development of cancer, leukemia, hereditary and genetic disease. How can you reduce the radiation dose? By four factors. The first one is the intensity. To reduce the intensity of radiation, you are going to reduce the radiation dose by reducing the time. Less time spent near source, less radiation received. By greater distance from source, less radiation received. Using shielding, behind shielding from source, less radiation received. The first factor we have is the distance. Based on inverse square law, there is inverse proportionality between the intensity of radiation and square distance. That means if you double the distance from 1D to 2D, so at that time, you will reduce the intensity of radiation to quarter. As you can see here in this area, this orange area, you will find the intensity of radiation here is highly concentrated. While doubling the distance, the intensity of radiation become less concentrated. That means at this area, at this square, the intensity of radiation will be less. Similar situation in our case in fluoroscopy. X-ray intensity decrease rapidly with distance from the source. Conversely, intensity increase rapidly with closer distance to the source. So as you can see here, if you have X-ray tube and our patient at a certain distance D1, so we will find the radiation exposure here is 64 units. But if you double the distance, you will find the radiation dose here is 16 units. At triple distance, 4 units, and so on. So if all other conditions are unchanged, moving patient toward or away from the X-ray tube can significantly affect dose rate to the skin. So our lesson today to keep the X-ray tube at the practicable maximum distance from the patient. What is the best geometry? The best geometry here, as you can see, to keep the X-ray source away as much as you can from the patient. As in geometry A, you will find the X-ray tube here at 80 centimeters from the patient. While in geometry B, you will find the X-ray tube here close to the patient at 40 centimeters. So, moving the patient away from the source will reduce the patient dose, will reduce the skin dose, and moving the image receptor close to the patient, as in geometry E, is best and reduce the patient dose incomparable with geometry B. Why? Because the image intensifier or the image receptor, when it close to the patient, it will receive more transmitted radiation from the patient. So no need to increase the patient dose to get a sufficient number of photons to get a diagnostic image quality. While in geometry B, when you find the image receptor away from the patient, so most of transmitted radiation photons will be away from the image receptor, will not be received properly. So at that time, the machine itself will increase the patient dose to get a sufficient number of photons to get a diagnostic image quality. So in geometry B, you will find the dose here is 4 times greater than the dose in geometry A. So keep in your mind, put the patient away as much as you can from the X-ray tube, put the image receptor close as much as you can from the patient. Second parameter here affecting on the patient dose is the patient size. Thicker tissue masses absorb more radiation, thus, much more radiation must be used to penetrate larger patients. Risk to skin is greater in larger patients. So, as you can see here, if you are going from 15 centimeter diameter of patient to 30 centimeter, if you goes from 15 to 20, so at that time the internal surface dose increase from 1 to 2, 3 units, and goes from 20 to 25, you will find the internal surface dose become 4 to 6 units. So you need double more exposure for every 5 centimeter increase in thickness. The third parameter we have is grid. Using grid, the grid is placed in front of the image detector. A grid reduces the effect of scatter. It's degrading image contrast, but it also attenuates the primary X-ray beam, both scatter and primary head grid strips. So as you can see here, the grid composed of strips. These strips able to attenuate the scattered and primary radiation as well. So not all primary radiation will be able to be received by image receptor. That's mean using grid will reduce the number of photons received by our image receptor. So at that time, the machine itself will increase the patient dose to get a sufficient number of photons to get a diagnostic image quality. So avoid use grid with moderate and thin size patient. That's very important to keep it in your mind. So using grid require 2 times increase in patient dose rate to compensate for attenuation and maintain same X-ray intensity at image intensifier as without grid. But also keep in your mind using grid, avoiding if you are not using grid, you will reduce the image contrast. Fact number 4, image receptor position. So if you are going to scan a certain point inside the patient, you are taking different angles or different projection around the patient. So keep in your mind to put the image receptor close as much as you can from the patient. But if the image receptor is too far away from the patient's exit surface, this causes high skin entrance loss. So it's acceptable to put the image receptor close or in contact with the patient's skin. So move the image intensifier as close to the patient as practicable to limit the dose rate and the entrance skin surface. Fact number 5, projection angle and peak entrance surface dose. Higher dose to the patient when imaging through deep, steep projections. So as you can see here, posterior anterior position, incomparable with steeper angle. So you will find here that the pathway of the beam of X-ray increase by steeper angle. That's mean there are more attenuation, more absorption, so you need to increase the radiation dose to get sufficient number of photons received by image receptor. So higher dose to the patient when imaging through steep projections, risk to scan is greater with steeper beam angles. So try to avoid steeper angle as much as you can. Projection angle and peak entrance surface dose. Reorienting the beam distributes the dose to other skin sites. Also, taking different angles will expose different areas of the skin, which reduce the skin cancer probability and reduce the skin hazardous effect. So reorienting the beam distribute those to other skin sites and reduce risk to single skin site. That's important to keep it in your mind. Small increment of angulation increase the overlapped area. As you can see here, the overlapped area between the two different projections. If you take in small increment, which cause this area is the overlapped area here will get higher radiation dose. So try to get large increment of angulation. Orienting the beam in small increments may leave the area of overlap in beam projections, resulting in large accumulation of overlapped area increased. Also, beam collimation. A good beam collimation reduces the overlapped area. Reorienting the beam in a small increment may leave area of overlap in beam projection, resulting in large accumulation of for overlapped area. Good collimation as well can reduce this effect. So try to collimate the beam as much as you can. Try to get large increment between different projection, which reduce the overlapped area, which reduce the radiation risk to this overlapped area. Reorienting the beam in a small increment, as I told you before, it is the same idea, but good collimation plus adequate rotation can eliminate this effect. Conclusions: in projection angle, orientation of the beam is usually determined and fixed by clinical need. When practicable, reorientation of the beam to a new scan site can lessen risk to the scan. So try to take different projections, expose different areas of the scan, which reduce the radiation risk to the scan. Overlapping areas remaining after reorientation are still at high risk, but good collimation and large increment can reduce the overlapped area. Factor number 6, collimation. What does collimation do? Collimation confines the X-ray beam to an area of the user choice. Collimation to square inside the image reduce those area product by 36%. Collimation, why is narrowing the field of view beneficial? Reduce cancer risk to patients by reducing volume of tissue irradiated. Reduces scatter radiation at image receptor to improve the image contrast. Reduce ambient radiation exposure to in-room personnel. Reduce potential overlap of fields when beam is reoriented. So collimation is very important to be done and to be used by our interventional radiologists to reduce the patient dose. But in case you are going to use the image intensifier, you have to keep in your mind that collimation will cause a reduction in the brightness, which means the machine itself will try to increase the brightness using automatic brightness control. So at that time, you will increase the patient dose. So on using image intensifier, try to avoid the collimation. But with digital detector, you can use it because at that time you will do it you are not using image intensifier. But image intensifier collimation, in image intensifier collimation is highly affecting on the brightness of the image. So at that time, the automatic brightness control will try to increase the brightness by increasing the patient dose. As you can see here, using the image intensifier, that's in case you are going to use image intensifier, and the collimation from 32 centimeter to 11 centimeter. As you can see here, the relative patient entrance dose rate for some units. Here is 100 units. In case you have a less collimation, 32 centimeters is the diameter or the exposed area of image intensifier, and your field of view, while here 177 to 22 centimeter, here 416 centimeter, 711 centimeter. Why this happened? Because reducing the field of view, which cause less brightness, which cause less number of photons will be received by the image receptors, which cause less brightness in the image. That's why the machine or the automatic brightness control will try to compensate the loss in brightness by increasing the patient dose. Thank you so much.